And so now I'd like to move to our next speakers. And the next speakers are also colleagues of mine. My close colleague, Professor Ann Matthews, and her postdoc. Can I call you Ella? Is that all right? Ella, how do I pronounce your last name, Ella?
It's Ellen Pieterse.
Pieterse. And Ellen has been working with Anne on a absolutely a wonderful project that has been funded by the IRC Coalesce project, and about issues in Malawi that they'll talk to you about more. But as many of you know, Anne has worked for years here in the School of Nursing, Psychotherapy, and Community Health, and is program chair for the undergraduate program in Health and Society. So representing our community health stream in many ways, both of these colleagues. So we've covered all of our different streams within the school. So I'm absolutely thrilled when they both agree or volunteered to speak today. So their talk is entitled Exploring How and Why Care Groups Work to Improve Infant Feeding Practices in Low and Middle Income Countries, a realist review, which I think is absolutely wonderful in terms of a different method for us to talk about. So I'll turn it over to you. You can share your screen if you'd like, and I'll let you.
Great. Hopefully you can see that okay.
No problem, and we can hear you fine.
Great, and thank you so much. What a wonderful day, and sharing of experiences and knowledge and perspectives. So thank you very much for having us included. I'm Anne, as Tanya said, and my colleague Ellen will be sharing this presentation. And we are working on this project overall about infant feeding policy implementation in Malawi. And we're just going to present and really focus on the realist review or realist synthesis work within that, because that's probably, more broadly, of interest to people. But of course, some people might be just interested in our topic, which is about infant feeding practices and specifically care groups, which is a globally used volunteer kind of cascading health education model of giving health behavior messages about feeding, hygiene, hand washing, and things like that. So looking forward to spending the next little while with you and answering any questions that come up. So I'd really keep an eye on my chat and my chatter, and Ellen will follow about halfway through. Just to say that we are a team. We now have about 7 or 8 in the team, which is brilliant. There's another 4 colleagues in Malawi currently involved with us. It has all been shifted around a little bit with COVID and some of the restrictions, which are still very much on our mind for our colleagues in the global south, where vaccines aren't featuring, or if they are, there's a really difficult implementation process. So we're very mindful of all of that as we have our 3-year collaboration. Tanya mentioned the scheme. So again, if anybody wants to specifically ask about that, it's the Coalesce scheme by the Irish Research Council. Our strand is funded by the Department of Foreign Affairs and through Irish Aid, the Irish Overseas Development Programme. Myself and Ellen Chirwa, Professor Ellen Chirwa, are in were the co-PIs when we applied in 2018. Aisling, our collaborator for a long time from the Royal College of Surgeons, and then thankfully Ellen came to boost our work, and everything about whatever we've achieved over the last couple of years has been down to Ellen's work. And just to say, it is that broad, very kind of wide-ranging proposal that we put in, but we did have in mind, that we would be involved in some. At the time, we said implementation research. I had done some training in UCC on that, which I found very helpful, but also on realist research, because we were seeing this as something that could help us to kind of dig a little bit deeper. Just on this slide, you'll see we're currently doing a scoping review on the Baby Friendly Hospital Initiative and the Baby Friendly Community Initiative. These are from the World Health Organization and UNICEF. You might have heard of them for decades, trying to bring in these 10 steps to support breastfeeding and safe and safe infant feeding practices, whatever happens to be the case. But definitely in a world where formula feeding and marketing of formula products is, overwhelmingly, let's say, stronger than the public health support for breastfeeding, these kinds of initiatives are needed to really embed kind of safe feeding practices within hospital settings to, start breastfeeding and then to continue them in the community setting. So we're doing a scoping review of that. We're kind of, well, hopefully halfway through that. We're currently extracting data within Covidence. We've about 260 articles about implementation of Baby Friendly Hospital or Baby Friendly Community initiatives. So anyone interested in that, please do get back to us. Lots of global work really on implementing that, and Tanya will know, and maybe others on the call, Gillian, that lots of work is needed on this in Ireland, and that's something really we're all hopefully going to pitch into to a greater extent. Ireland being fairly back of the queue in this in breastfeeding rates at all, and definitely exclusive breastfeeding rates, which is what's recommended by the World Health Organization for all babies born, that they're exclusively breastfed, so fed nothing else, only breast milk for the first 6 months of their lives, and babies all fed up to 2 years with other foods. So we've a long way to come in that in Ireland, and in a way being very conscious of that in this project, that we're not coming with a group from Ireland who have the answers. In fact, we're really trying to see how we can transfer back in that reverse way that's spoken about now, what we need to improve in Ireland. But on to the main topic, which is our realist synthesis. So myself and Ellen will use these terms interchangeably: realist synthesis, realist review. And this was our topic. This is our topic. We have just concluded, you could say, the realist synthesis. Ellen has sent off 2 articles on our realist synthesis. And I suppose, we chose to focus on this today because it's been such a big learning curve for myself and Ellen. We've both undertaken training with people who are expert and experienced in realist research, and yet certainly for me, I feel it's kind of the tip of the iceberg, but we've been able to apply what we know so far to this idea of care groups in Malawi. Well, not just an idea, but also a widely, as I said, a globally used mechanism, mostly by international NGOs, to kind of cascade down training through promoters and care group volunteers, mostly women, down to families. Each care group volunteer takes 10 families in a local level. So we got interested in this because when we first visited Malawi in this project in 2019, everybody was saying that the care groups will sort out, will look after, will solve, the kind of community level problems. So we realized that while there were lots of reports saying these are really successful, we didn't really understand how. And as that little note off to the side just says, it is a secondary design, a secondary research design. So we're working with other people's data as recorded in lots of different ways, in published articles, in grey literatures, in evaluation reports. Excuse me. So it is a desk review, but a part of the realist methodology, whether it's primary or secondary, usually recommends having a kind of a reference group or a group of stakeholders to kind of, well, to check in with, to make sure, does this make sense? Is this what people have experienced on the ground? So in that way, we have this reference group of experts, both on care groups, on infant feeding, and then in our case, people involved with us in Malawi in that context as well. Sorry. So just very quickly, I suppose, as I've implied, this realist evaluation approach, rather than just saying, like, here's a table which shows baseline breastfeeding rates, exclusive breastfeeding rates, and here's an improvement because we had care groups. It's really trying to dig in, you know, how does this work? How did that change come about? So not just does it work, because sometimes evaluations do want to know that, and especially when they're funded, you know, by a funding organization, there's an evaluation which kind of has to say, yes, this worked. Look, it increased by X% of breastfeeding or whatever other practices. But in our case, and in the realist approach, drawing on critical realism, anybody who comes to realist research will very quickly come to Ray Pawson and Nick Tilley's work. Ray Pawson was at a realist conference we were at online earlier this year. Or was it last year? I'm lost, and commented on our emerging work. So this is a really good open community, very helpful. There's a wonderful email list called the Rameses Group, based on the Rameses project, which developed good, really strong guidance for realist reviews and realist evaluations. So this idea of what works for whom, in what respects, to what extent, in what context, and how, so that we were drawn to that idea. You know, to be honest, we wanted to develop our knowledge about realist methods, so we were looking to apply them. And when we came across this idea of care groups, when I say idea, because, you know, nobody really kind of understood, maybe to the extent we wanted to know, you know, what's actually happening and for whom and where. So as you can see here, you know, it is becoming a more popular approach applied to health care, social care. I mentioned these Rameses publication standards. So these set out, you know, what should you have in your final realist publications, and therefore you build those into your protocol. You know, we've published our protocol for our realist synthesis. We got good feedback on that. Then so we registered it, first of all, our realist synthesis. We published the protocol, and now, as I say, we've the 2 publications so far coming out, and hopefully you'll see what's in them shortly. So, you know, big acceptance, I suppose, World Health Organization, UNICEF, the NHS, that realist research has something to offer that adds to the other, maybe simpler questions in evaluations. Did this work or not? So I've kind of said this, and hopefully you realize that when things are complex, maybe then the kind of context and the role that plays is really important. You'll see these this acronym CMO coming up again a few times, especially with Ellen's piece: context, mechanism, outcome. The mechanism is kind of invisible. It's not the training package, the people. It's kind of what happens in a certain context with an intervention interplaying what is happening that we kind of can't see, and then what is the outcome that we probably can see. And there's our protocol again. We're happy to share anything of that. And I think I'm coming up to maybe my last slide or two. I suppose there is a very, you know, there's a good guidance on how to carry out your realist review in our case. So we're sticking to just the secondary review for the moment. We're hoping to do a realist informed evaluation of care groups shortly in Malawi, pending public health guidance and all of the rest. So I suppose what we did, we initially read our care group texts. We formulated some initial program theories. So this is typical of realist research. It is a theoretically driven design or approach. So, you know, you're explicitly theoretically, you know, identifying theories, and then looking to amend your theories, revise your theories, with the data that you find, whether from the secondary data or your own original primary data in an evaluation. So we looked through all of the published texts. We included or excluded based on our criteria. We coded, as you would do with qualitative data generally. We transferred those into in vivo. We grouped our evidence according to these CMOCs, so context, mechanism, outcome, configurations. We analyzed that evidence and then wrote those up and went back and forward to the stakeholders. So we did publish that protocol, as I mentioned, and we've 2 realist synthesis articles in a journal where a lot has been published about care groups, you know, in the kind of, here's the baseline, here's the outcome. And then we really want to publish some more about our, you know, about how we went about our realist review, and then maybe our evaluation, all going well. So I think I'll finish on this slide just to say, this is really a place where sticking to peer-reviewed articles will not really find you the kind of evidence that you need. So you can see from the final column here, we have 8 peer-reviewed papers, 11 case studies, 2 kind of how-to documents, kind of guidance documents, 22 evaluations. So these are, some of them are evaluations like where indicators are measured, as I've said. Some are process evaluations, which were really useful. So we started off with this wider 82, reviewed them lots in pairs, lots of times. And so these are examples of the kind of things. Some are articles, one on the right, others are maybe case studies on the left, and an evaluation report in the middle. So Ellen, I'll hand over to you now. If you want, I'll keep going on the slides. You can tip me off as to when to move forward.
That's great. Thank you, Anne. That's great. Thanks for the introduction to what we're doing. Yeah, so as Anne said, the realist research is all about the interconnectedness between the context, the mechanism that's going on often in people's heads, or somehow it's something that sparks people into making a certain decision and taking a certain action, and a certain type of outcome. As researchers, we work with theories, so we come up with initial program theories, and these initial program theories are kind of written in as CMO or context mechanism outcome configurations. So the idea is that you work with a lot of middle range theories that kind of explain that in the context of the intervention that you're looking at, in this context, we think this mechanism sparks leading to this particular outcome. And so you comb through your intervention and through all your texts and come up with all the different ways in which you can explain the outcomes that you encounter, and you look back into the contexts that are at play for various actors. So in our case, I don't know if it's a little bit hard to see, but we look at care groups, which is so a peer-to-peer mechanism. So you have a care group volunteer, so a leader mother who receives the lessons, and then she has a group of maybe 10, 15 care group neighborhood group members. So these are women that live around in her house or her neighborhood, and she shares the learnings that she receives every month with that whole group. And then there's lots of different actions that are going on that involve, for example, the communities that the wider community that the intervention is set at. The wider community has a role to play in terms of supporting women to adopt new practices, new behaviors in terms of hygiene or accessing healthcare or accessing antenatal care, continuing breastfeeding, which may be something that's culturally inappropriate if a woman is pregnant with a subsequent child. There's loads of different ways in which communities have great influence over women's behaviors in the context of infant feeding. And then there's also obviously the wider context, the health center, the health facilities. They have a big their accessibility and availability of care obviously has great influence in how much women can take up or can change their behaviors in terms of taking up healthcare that may or may not be accessible. And then there's the NGOs. Care groups are there's also the Ministry of Health and their policies and practices, how they influence again on the context. And then there's the NGOs that play a role in delivering this program and how they influence the various actors in the various contexts. So we theorize how each of those different players interact with, in their own context, interact with the peer, the care group intervention, and how that leads to outcomes. And really what that leads to is for us a table of context, mechanism, and outcome. Sorry, just the last thing. So you have a table of CMO, so CMO configuration, CMOCs, and then each of those needs to be either confirmed or refuted by the text that you that we're working with. And at the outcome in the end is either a confirmation of these middle range theories, or maybe a subtle change, or maybe a complete change in these theories that actually informs you in future, if were you to implement such a particular intervention, it's likely that in this context, that outcome might occur because of this particular context, so, or this particular mechanism that might be at play. So the idea is that you end up with a more refined set of program theories that will give you a basis for further implementation at a different time, at a different location. Yeah, sorry, the next slide. So here, this is an example of how we worked with each of the context, mechanism, outcomes. In our first one, we were concentrating on the care group volunteer. The idea was that the care group volunteer, in a context where a woman is elected as volunteer and provided with meeting structures, with manageable workload, with a T-shirt distinguishing her from other people, flip charts, some other items that really that really set her up for spreading this learning. These women, these volunteers, can be motivated by all of the things that are provided, and this will encourage her to remain in the program. I mean, it's a fairly basic kind of structure. There's a basic kind of idea, but it's also important to test all of these basic theories and then more complicated theories. And here are two examples of quotes. So I won't read them, but these are two examples of quotes that you then lift out of your text in order to provide them in your documentation to say, okay, here is enough evidence to say that this particular CMOC is confirmed by us. So the next one. So what we found is that we had three different findings that related to the care group volunteers and to the neighborhood groups, and they all had to do with motivation, self-efficacy, and empowerment. And what we found is that both with the volunteers and also with the community groups, that they were kind of, through the care group scenario, they were experiencing different ways of being motivated and encouraged. Initially by the training, by the supportive supervision, or by the fact that this group and this information was made available as a resource. And then over time, the community response, the positive feedback, the relationship with the neighborhood group, then kind of generated some sort of positive and self-sustaining group dynamics. And then a certain level of self-efficacy started to emerge, feeling confident and respected, trying new behaviors, maybe seeing the positive results from these behaviors. And what's interesting is that, well, when we were talking or presenting these findings to NGOs that use care groups, they were very surprised to see that it's not just their training and the T-shirt giving and everything else that kind of that keeps these care groups going. There's actually a lot more, and it also allowed us to draw attention to the fact that the group dynamics are extremely important, and it's really important that an NGO that implements one of these care groups is really mindful of cultivating these group dynamics and nurturing these group dynamics. So you can see that a very theoretical process actually brings some really strong kind of practical evidence to the fore. The next slide is just a sort of a drawing out of this exact same kind of phenomenon. Three different types of kind of motivation to keep these care groups going. If you have time to look at the slides, if you're interested, or contact us, This is, you know, this is kind of a way of drawing out how context, mechanisms, and outcomes flow together, and how you see sometimes that a particular outcome also then becomes a context again for another type of mechanism, another type of dynamic that starts to spark. So that is kind of a great thing about realist research, that it really goes into these individual context, mechanisms, and outcomes, and really dissects them in order to see how the interplay comes together. And it brings up lots of really interesting findings. I think that's our last slide coming up now. Okay, so maybe a few more minutes for questions. That's all we have to say, really. It was just great. Our research has brought up lots of kind of deeper understanding of how care groups work, multidirectional nature and group dynamics and motivation. And as I said, you know, there was a lot of positive response from different NGOs that are working with care groups. And then also we looked at the inner workings of care group implementers and how they work within community, influencing community members, influencing village leaders, influencing health workers to create a conducive environment, which again is something that hasn't really come up in the care group literature, but it really emerged out of the case studies and out of the other literature. So that was really fascinating as well.
This is
time for a couple of questions.
great. Thank you so much. So this is really interesting, and I know that our school has a long tradition with the more quantitative, although the Cochrane review does have a qualitative component as well, and Anne has worked in that as well in terms of reviews. So this is really a nice set of qualitative critical review, realist review that I think is wonderful for us to look at. Can I ask Ellen the question? So the actual text itself, do you take, so are these, you made the point that it's not just published, so there's other things, and then do you take the whole text and insert it in vivo and then treat it like you would an interview type thing?
Yeah, pretty much. I mean, you could do it that way, or you could, I mean, what we did, we actually did a lot of pre-in vivo coding in Excel, and there was a lot of kind of reading and rereading of the text, and we kind of identified relevant pieces and relevant sections to cite, and they ended up in vivo. I mean, you could upload all of your texts in vivo and do it that way. Actually, that would be kind of the same, but it is like that. You treat your secondary sources as if they're primary sources in a way, and that's why it's so useful to when you work with a lot of gray literature, when you work with a lot of evaluations or kind of case study sources, any kind of sources that are secondary but are so close to empirical data that you can almost, you know, take them as first, you know, as primary sources in a way. And that's what makes it so interesting. You don't just go to the numbers at the end of an evaluation, just look at, oh, improvement of this many percentages. It's, you know, you really look at and you delve into the rich data that's in between that kind of explains kind of the changes that occur in, and that kind of data comes out of interview data or case studies or any kind of anecdotes that might be contained in a review in a review of
that sounds really interesting. And the one other question that I would have, so how do you decide what becomes included and what doesn't? Do you have things that you've found and rejected, or
in terms of the papers or in terms of the citation?
In terms of what you chose to have as data for your?
Yeah, well, basically you're quite rigorous combing through all of your literature sources, and you try to code everything that's relevant to a particular CMO that you have developed. So you kind of gather all of the material, some of which might really confirm the CMO, so your theoretical proposal or the theory you've developed. Some things, some certain literature pieces might refute it, and very often, and this is kind of a big part of realist research, it's all about kind of updating it and fine-tuning your theories and really improving your theories. So instead of a theory of change being based on what you make up at the beginning of a project, you write it into your funding proposal. You say, well, I'm going to do this, and then that will be the outcome, and this is how it happens. You actually go and test those theories of change in a way by finding every piece. You know, we kept on rereading through our 42 pieces of text in order to find everything that had to do with each of our CMOs, to ensure that we have everything that, you know, everything that has to do with the particular theory. And then by rereading those individual sheets, we brought it back out of in vivo and onto Word documents. By rereading those, you then refine your theories.
So that all sounds really great and really interesting in terms of things. I'm looking forward to reading the articles that you publish. I would suggest some of the infant feeding journals would be interested in looking at this as well. So like Maternal and Child Nutrition often publishes qualitative work, and so that might be a place to think about it. Certainly, you know, some of the others do as well, but I think the audience might need more guidance often with the method as well. So so I think it's great to go to those places that understand part of what you're trying to do, but also trying to go to some of the others to give the knowledge to other people working on the topic as well, I think is great. So, well, thank you so much.